To lead this next session, I would like to invite Dr. Krishnakumar M, Professor of Medicine, Kochi. He has more than 32 years of medical teaching experience of postgraduate and undergraduate students in India and abroad. Over to you, sir.
Good morning to all of you. The next topic is actually a continuation of the previous topic, something like reiterating the points given by the previous speaker. And the topic is about sulfonylureas. Changed. In my brochure, it is written as sulfonylureas again.
Yes, sir. Yes, sir. It is about sulfonylureas.
Yeah. The speaker knows the best. The speaker knows the best. We have a very good speaker. I was just reading about him. I'm sure I've seen him in some conferences before. Dr. Sreenivasa Murthy from Bengaluru. He is a very well qualified senior consultant physician and diabetologist from Bengaluru, and he was principal investigator in many studies, a very star-studded CV. I don't spend too much time describing all these because the proof of pudding is in tasting. We can listen to him. Just one point randomly. Ambassador car is coming back. Ambassador is making a beautiful new car. So we cannot get away with the old things. Sulfonylureas were discovered as an accident when they were modifying an antibiotic, sulfa antibiotic. They found that in 1954, they found that it reduces blood sugar. That was the beginning. And then they modified because of side effects and severe fatality. They modified the molecule again and again. And in about 4 or 5 years' time from there, tolbutamide came. That was the beginning of sulfonylurea. Many of us were not even born then. And then I would like to ask one question if you don't mind.
Sir.
How many of you are still prescribing any sulfonylurea? Yes. We have many hands. I mean, most of you are. I don't think anybody has just completely stopped using sulfonylurea based on the new guidelines. The criticism about guideline-based medicine is guidelines are just guidelines. And the main criticism about guidelines is that it looks at only the disease and not the patient. And definitely not the patient's pocket. So we have to adjust. And this is an era of precision medicine, so we may have to use each one of your armamentarium in the selected patient. I'm sure he's going to elucidate more on this. Please.
Thank you, sir. I think you have done most of my talk and people have accepted it by raising hand, so I can say thank you and leave. But as a formality, I'm going to proceed with my talk about the enduring value of SUs, type 2 diabetes. And just to start around the burden, I'm sure all of you are aware, 3 out of 4 adults live in the lower socioeconomic countries. That is where our role as physicians, clinicians is very important. Almost 1 in 2 adults live with diabetes unaware, and that's the worst thing. And you can see in Southeast Asia it's about 51%. That is something we need to remember. 87% of this more than 3/4 of the people live in these low and middle income regions. So the alarming proportion of undiagnosed or pre-diabetics, even recent ICMR India study clearly showed this, the burden is so much in our countries. And of course we are expecting 25% increase in this diabetes in our country. And this is about the very sad part of the control of A1C in spite of so many drugs, so many newer technologies, and the average is, you can see there, is anywhere between 7 to 8, that is 7.9 to be precise, an average Indian HbA1c, and the onus is completely on us because we have the inertia to uptitrate, to add drugs, to insulinize patients whenever required, etc. And the onus is completely on us. So sulfonylureas are the ideal drug, as sir was talking about ambassador cars. We used to 15 people used to travel in ambassador car. Now, 5 people in a lift, it will give a beep that you are overweight or overburdened. But that is what used to be the capacity of ambassador and Fiat cars those days. And sulfonylureas, as agreed upon, we are the people who are using it still, and as 3/4 of the people here raise their hands and show the evidence, what is the number of prescriptions and the proportion of usage of SUs in clinical practice routinely as of today. And of course, we always look at the holistic person-centered approach, where you need to talk about the glycemic management, you need to look at the weight and glycemic control, and all these to put together is in the patient-centric approach. Remember about the CV risk factor management and cardiorenal protection, the glycemic control, and this is what we need to look at in a holistic approach. This is of course ADAAC, which is being updated every year. But remember, the glycemic management is the first step, cornerstone in any management. Just to show you the evolution of glucose lowering agents, you can see the last 2 decades have been very, very fruitful for us to treat our patients. As you can see, the development of DPP4s and SGLT2s, and I've been involved in this from about 2003. My first research molecule was, I was involved in the clinical trial was sitagliptin way back in 2004-5. And of course, the first sulfonylureas sir was talking about was accidentally detected because the antibiotic induced hypoglycemia in the Second World War victims. That's how all this started about and it was a French molecule which is developed, and glycoside was patented way back in 66 but was launched in 1972, and glimepiride 79 and 95. So this is what is the history. Now this is just to show you, reiterate the fact, 30% of the second line treatment are SUs, and SUs monotherapies are in combination. That's the extent which we use, and you can see the data very clearly talking about sulfonylurea combination amounts to 30% of this. In spite of insulins, DPP4s, etc., this is the most prescribed because all of us are aware when HbA1c is 8, 9, 10, this is the drug which is going to bring down, not your DPP4s, except GLP-1s and insulins. No other drugs can match as far as the A1C reduction is concerned when it is bringing down to the more than 1%. So just to show you real world usage, it's called JADE, Registry Joint Asia Development Diabetes Evaluation. You can see 60% treated patients received SU-based therapies. You can see all our Southeast Asian countries, including India. So this is the belief we have about the sulfonylureas and its potency. And of course, this is SU regimens. You can see there, SU plus metformin is 80%, DPP4 and SUs are 22%. So 80% of our prescription literally has a SU along with, of course, metformin. Now, the drug-specific and patient factors to consider when you select the OHS. So these are the columns you look at because you need to look at the efficaciousness of the product, the risk of hypoglycemia, the weight, CV benefits, and progression of DKD, and of course the cost. This is one of the primary things which most of us look into in our practice, except few of us where we have a high income stage. But the lower the better for most of our patients, that there is no doubt. So we need to look at this segment also in our country because it's an out-of-pocket market. So this is something we need to look at. So the SUs have got a very high efficaciousness, metformin, TZDs, and as you come down, except the GLP-1s, these SGLT2s, DPP4s, I always say they are like a jockey, but you require a good horse to ride. So the horse is SU or metformin. Above that, you sit with a good jockey, then you can win the race. So it's very important for us to realize that you can see the high efficaciousness, hypoglycemia risk definitely is, and weight gain are neutral. I would say from my side, I'll show you in consecutive slides some evidences for this weight neutrality, effect on males, and heart failure, and progression of DKD. And so you have this plus one of these combinations you can think about with metformin. That is what will help our patients. Now the classification, you know the first line, second line, and third generation. Third generation is modified glycoside, glimepiride, and glipizide. Now the key mechanisms of action, we know it stimulates the insulin secretion by pancreatic beta cells through the SUR1. That's the very specific high affinity for SUR1. And it causes cell membrane depolarization, voltage-gated calcium channels, and resulting in influx, and of course, exocytosis of insulin granules happens following the stimulation. Now let us look at the glycemic efficacy, CV safety, renal outcomes, and risk of hypoglycemia. This is what we need to categorize for any given OHA. So look at the glycoside, which is the most effective oral antidiabetic in the therapeutic analysis, GIA meta-analysis, which showed that the glycoside shown twice it's more effective than DPP-4, 3 times more than your SGLT2s. This is what gliclazide do. Even glimepiride is there in the list, you can see that. And of course, this is one of the earliest evidences which we have for way back in 2008, the advanced arm and advanced hypertension arm. This was a wonderful, one of the earliest trials, I would say, RCTs, which clearly showed, which was a landmark trial with about 11,000 plus patients and diabetics beyond 30 years and average A1C of 7.5%, and also BP arm was there, and of course age was more than 55 years. So this is, you can see it's a multinational, multicentric randomized control trial, which has got the patients at an average diabetes duration of 8 years. So that is something point to be noted. Even after 8 years, now we talk about beta cell exhaustion, etc. Gliclazide still worked in this trial, where it assessed the effects on the micro and macrovascular. Before all these, your SGLT2, GLP-1 trials, RCTs, this was one of the landmark trials which clearly showed it can lower A1C to below 6.5% in the intensive arm and the classical arm there was. And this is another reiterating factor where across BMI, age and the duration of diabetes and the EGFR levels, you can see the reduction which is effective in reducing the A1C. You can see the BMI, you can see the age factor also here, 65 below and above they have categorized into 2, and in both it has worked. And remember at what cost we will show you, because hypoglycemia is something which we always worry in the geriatric population. And of course the duration of diabetes, more than 15 years also, there is a category you can see there, and 5 to 15 years, average was 8 years duration of diabetes. EGFR 90 above and below, and below 60. You can see the last column, below 60 also has brought down a A1C of 0.8. Now this is what is the final A1C reduction, and you can see there 6.5% from standard, which is 7.3, that is the standard arm, and this is the intensive control. And you can see the reduction in the micro and macro. This is one of the earliest trials apart from ACARD, VADT, etc., which showed the cardiovascular benefits to the tune of 10% reduction, both micro and macro. Remember this, because most of the studies until then were showing only about the microvascular benefits. This was one of the earliest trials which showed the macrovascular benefits about CV as well. And of course, this 10% reduction in micro and macrovascular events were in the early intensive group, that we hit hard, hit early. What we had today talk about was shown way back in 2006-7 and was published in 2008. So you can see the combined major micro and macrovascular events in about 11,000 plus patients with a 5-year follow-up to the tune of 10%. So there was 21% reduction in the worsening nephropathy, and this was the most driving factor with all this 10%, was mainly because of the renal benefits. CV mortality 12% reduction, 8% majority coronary events called MACE events, and of course 7% all-cause mortality was seen the 5-year duration. And you can see the minimal insulin requirement over 5 years, which suggests that there is no beta cell exhaustion or overstimulation by your gliclazide. And this is what is very reiterating. The delay in insulinization is also seen because of this molecule over a period of 5 years. And this is something which is very important in our routine clinical practice also. The insulin to the tune of 20% reduction was seen. Now let's look at the other trials at the same time. Of course, SAVOR, TCOS and EXAMINE were all the DPP-4s. ACARD was with the glimepiride. VADT was with again glimepiride, metformin and insulin. And you can see the red ones in ACARD, it was stopped early because of the intensive control where the A1C brought down below 6% and there was a MI. So it was called off very early, one of the few trials which showed worsening, and also you can see the SAVOR TB, which showed the worsening of heart failure, and the molecule literally disappeared from the market after this study, where the heart failures for hospitalization were more. Now look at the advanced vis-a-vis about all these, all are greens. What are those? The MACE events, you can see their MACE events, hospitalization for heart failure, and ESRD. You can see the ESRD part, none of the other trials, which includes your gliptins, did not show. Of course, we are not included here in the linagliptin trials, but these other trials, vis-a-vis, you can see the renal benefits with the sulfonylureas. So, how is it different from the other class in the same newer sulfonylureas? It's because of this unique structure. You need not worry about this. You can remember as an octyl ring, which makes the difference, and this contributes to the clinical differences what we see with the efficaciousness of the hypoglycemic events, which are better, and also the cardiovascular safety and renal protection. You can see the ring which is extra here compared to glimepiride, glipizide and glimepiride. So this is how it exhibits the rapid reversible binding to beta cell, and thus it has got lower rate of hypoglycemia and weight neutrality, unlike the other two molecules of glibenclamide. And this is what is the specificity for that. Whenever the affinity is more, that means it is better and lesser side effects. So unlike other sulfonylureas, glycoside does not activate this EPAC2, and that is where it has got that cardiovascular neutrality, and it is very specific for that, and that's why it does not overstimulate the beta cells also, and the lesser incidences of hypoglycemia. Now we talked about the advantages, the safety part. Let us look at in the form of hypoglycemia, because any OHAs or any insulins, we need to look at the hypoglycemic evidences. That is what we are worried about, and that is one catch which the SUs are always got. But in real world practice, the SUs are used the highest as I showed you, but also the entry level A1C, whenever somebody comes 8-9, there is no question of hypoglycemia. So 90% of the hypoglycemia happens when the patient does not consume the food on time, delayed or physical activity which is unusual. That's how they end up with. So if you educate them, there is no question of hypoglycemia occurring because of the molecule. That we should keep in mind. Now, the risk compared to newer agents, which is the second line, and all the other things you can see there, glycoside has got compared to glibenclamide, glipizide, glimepiride, metaglimide, the glycoside is somewhere there. Of course, the DPP4s are one of the safest ones to have whenever there is a risk of hypoglycemia. And of course, vis-a-vis glimepiride, you can see the reduction, which is about 2 times lesser. That's something very important. To emphasize this fact, the less risk of hypoglycemia, I am showing you a guide study, which is head-on study, double-blind comparison of once IV glycoside and glimepiride in type 2. So double-blind means even the investigator or the patient do not know about this molecule, and they have a 70% less risk of hypoglycemia. And that's the beauty of this paper. It was called guide study. And glycoside DPP4s similarly having low risk of symptomatic hypoglycemia during Ramadan. During Ramzan also, this is study which most of us will read it. Of course, we'll give it in the night. But this is what is a re-emphasizing factor, that even during the fasting periods, glycoside, DPP4s were compared. And of course, DPP4s are one of the safest ones, and glipizide is also can be given in such, which is a short-acting ones, especially in the renal failure when there is EGFR less than 45. Glipizide is definitely preferred over any other thing. Other than that is insulin. So there was no weight gain observed in patients treated with glycoside compared to other agents. This is what I was talking about, where compared, you can see all the major pre-trials are done, including Wikipedia with the glibenclamide, and the advance literally showed no weight gain or weight loss. So it is very neutral what is seen with this, and you can see glimepiride to the tune of 8 kilos. There was a weight gain, which is seen, of course, in the routine clinical practice also. May not be to the tune of 8 kilos, but definitely weight gain properties of glimepiride is no. Now the cardiac safety part, because that is another thing, SUs are good, and glimepiride also had a blessing in disguise in the form of Carolina and Carmelina, where it was compared with linagliptin and proved safe. And this we have been having evidences from more than 2 decades. You can see this paper, which was a nationwide study, cardiovascular safety of glycoside compared to metformin, about 9,000 plus patients with past history of MI. Cardiac safety was 0.29 for glycoside versus metformin, increased risk for glimepiride versus metformin. So you can clearly see there the difference, the forest plot to the left, clearly indicating, and this was a paper published back in 2011. And of course, the cardiac safety is because, as I told you earlier, the highly specific affinity towards that SUR1, and that's where even in pancreas levels it does not induce the beta cell exhaustion. What about the renal outcome? Way back in 2008 itself, it has shown that the major contributory factor for the reduction in the cardiovascular safety of this molecule was mainly driven by this albuminuria risk and the prevention of ESRD risk. You can see the albuminuria risk progression 30%. That is the best part in the intensive arm which was seen, and the progression to the ESRD is reduced to the tune of 65%. And of course, advance has got 20% regression rates from macro to normal albuminuria. This is another thing which also is, the patients are getting benefited whenever you have this apart from the reduction in the events. 46% reduction in the ESRD, the intensive arm, in advanced on trial, which was another sub-study, apart from the hypertension arm, they had advanced on which continued after 5 years till the 10 years, and this from 11,000 the patients were 8,500. They continued in the advanced on trial, which showed the reduction in the overall ESRD to the tune of 46%, and the ESRD, CKD subgroups, you can see the better outcomes with the preserved EGFRs were also observed in this over a period of 10 years. And of course, 21% reduction in the nephropathy. This is again seen in the intensive arm. You can see the forest plot again favors the intensive arm. Now, different SUs in ESRD, very practical slide talks about all the SUs which are there. You can see glycoside and glipizide are much more safer when it comes to the exposure to the renal impairment. With caution, you can definitely use below 45 as well, but of course up to 30, and after that we do not use glycoside and glipizide is the safest. So the lower risk of doubling of creatinine in the glimepiride versus glimepiride, again about 4,400 patients with the preserved renal functions were seen where there was a reduction of doubling of creatinine versus glimepiride. These are all the renal endpoints which we look at in clinical trials. And of course, the real life kidney outcome in type 2 diabetes, glycoside versus glimepiride, again comparative study which clearly showed about 76% lower risk of ESRD in patients with the HbA1c. And in this, you can see it's a South Korean trial with 2,800 plus patients. Retrospective real life, it was an observational study. ESRD, you can see when the A1c is less than 7%, you can see the reduction to the tune of 76%. This is another paper which talks about the comparative effectiveness of glycoside modified release versus the sitagliptin as second line treatment after metformin monotherapy. And this is where you see 35% more likely to reach the target A1c of less than 7%, 35% more versus your sitagliptin. Thank you very much for patient hearing. Any questions, I'll be very happy to take it.
Thank you for that wonderful talk, crisp and comprehensive. Even though the topic was about sulfonylureas, I would say that you planned it very well, pivoting around the glycoside. Because at present when we say sulfonylurea, basically we consider glycoside first. Of course, it's a short-acting molecule, but you have to use the extended release to get these desired effects. And yesterday, a similar topic was discussed in the other hall. And immediately one person asked, so you mean to say the current guidelines are useless? These drugs are not useful? No, it's not like that. In kindergarten, if you tell one student you're good, immediately the others will come and, what about me? What about me? Am I not good? It's not like that. We have an armamentarium which has to be used by the clinician according to your experience, your priorities, and of course the patient's priorities. Cost is a big factor, as he clearly told. Very wonderful talk. Please give him a good hand. Any questions, comments, please?
Yes, sir.
So much benefits in nephro. It's a micro risk. Not in retino and neuro. Is there any evidence?
No, sir. I don't think there is evidence on that in the advanced trial. See, because these are all evidences through randomized clinical trials. Okay, so as I told you, back in 2008, the macrovascular benefits were never seen. This was one of the first trials which showed. I am not aware about the retinopathy with respect to this molecule in advanced. Yes, sir. I think it's not on.
Nice talk, sir. Just one doubt about how to uptitrate the dose. How do you start? What dose do you start usually? Especially the extended release form, and to what dose do you titrate? And how, whether it is once daily, twice, or thrice daily?
Okay, I think it's a case-based case. It applies to every molecule, depending on the age, the fragility of the patient, the systematic diet exercise pattern if a patient follows or not. These are the factors which the modified release is one of the best combinations to start with 30 or 60. That's what I usually do it. And 30-60 OD is a wonderful combination. Add on to your metformin. And the second line, especially when the A1C is above 7.5%, I blindly start with this. There's no SGLT2, there's no DPP force when the A1C is. See, these are all drugs which will give you the reduction. See, whatever we talk about the pleiotropic benefits of these various molecules, without A1C being less than 7 or 7.5 in a given patient, what do you do with your pleiotropic benefits? Because you have not corrected the basic pathophysiology of A1C. The sugars are not well controlled, and you add SGLT2, GLP, triple G, 2G, etc. It is not going to benefit the patient. So the first goal is achieved by these combinations of metformin sulfonylurea. In fact, in India, highest selling brand is that, the combination of these two drugs. So it depends on the case by case basis, EGFR, the fragility, smokers, alcoholic, what is the profession, all these factors you need to factor in. There's no one size fits all for any drug. I would say it's only that DPP-4 is where you can close your eyes and give and say no hypoglycemia risk. Otherwise, all the other drugs you need to do something like EGFR for SGLT2, GLP-1s you need to talk about the gastritis or the side effects of GI, etc. Similarly, in this is what you should look at a case by case basis.
Yes, decades back itself, ADA has mentioned, you do whatever you may, get the sugars under control. That's the primary aim. Just like we talk about AC inhibitors and renal protection, we give a lot of importance to that. But then, if you don't control the blood pressure with AC inhibitor, then there's no renal protection. You have to get the normal values first. So at any cost, bring the sugars to normal. That is the primary aim. And this hypoglycemia scare, diabetes is a disease which requires a lot of discipline. Discipline from the patient, discipline from even the caregivers. So if a patient is erratic and takes food at will and indulges in alcohol at will, it will be very difficult to get a normal lifestyle. And all the studies which we see, it takes for granted that the patient is following the lifestyle and the diet. And then the studies on top of that. And often our problem is a patient who doesn't obey our instructions. So if you don't have a patient who is compliant, values will change. Values will be erratic. Am I right, sir?
Correct, sir. I think that's why all of us are surviving with practice because they don't follow the guidelines.
If there are any more comments or questions, thank you very much,
Thank you, sir.
Dr. Sreenivasa Murthy. Thank you.